then that means the autonomic nervous system is affected. So please remember that as if the baby is swimming all the time, the amount of time is spending underwater and the time which is spending at the baseline. That gives you a clue as to what is happening. Remember that you have to look at this CTG anytime to the CTG when the baby started in labor, when the stress was minimal, then you know what the differences are and you will be able to manage the case well. So we will go to the actual trace and see how we are going to interpret this trace. So I mentioned about the baseline rate created by the SA node modulated by the sympathetic, parasympathetic and the vasomotor and the baroreceptor mechanism. Now sudden rise from the baseline and sudden fall are called accelerations, provided they are 15 beats from the baseline and lasting for 15 seconds. So the paper speed here is 1 centimeter per minute. So here the acceleration is lasting for 30 seconds. It is going from 135 to 155. So it qualifies for an acceleration. If you get a number of accelerations, that means the baby is healthy, because accelerations are due to fetal movements or activity in the somatic nervous system. The brain has two components, the somatic and the autonomic nervous system. Soma is the voluntary muscle movement. So if I am going to do something, grab this bottle of water, my heart rate goes up a little bit. And as you could see from the bottom of this picture here, with the fetal movement, acceleration corresponds, as you can see. As long as there is motor activity, even if you give pancuronium and paralyze the baby, as long as there is motor activity, there are accelerations. These are not due to cortical, but due to subcortical. So even with an anencephaly, you can get accelerations. So it has nothing to do with intelligence, but it has to do with oxygenation. If the oxygenation to the subcortical level is okay, or to the motor system is okay, then you get acceleration. Horn and Paul defined this trace. There are two accelerations as reactive CTG, which you would have heard time and again. Reactive meaning the baby is reacting or responding to fetal movements. Every time there is a fetal movement, the baby has an acceleration. That means the somatic nervous system is okay. Now, before it affects the autonomic nervous system, the somatic nervous system runs into trouble. So if it is due to infection, hypoxia, cerebral hemorrhage, anything, first system to go off is the somatic nervous system, because the autonomic nervous system has to be there to keep the person going. So if a person is dropped down on the floor unconscious, the person might not have any movement. The somatic nervous system is knocked down due to diabetes or uremia or whatever it is, but the autonomic nervous system keeps going. So the autonomic nervous system is reflected here by the baseline variability. The sympathetic system pushes it up and the parasympathetic system pushes it down. Now, although I'm giving this talk and I'm looking straight, I'm fairly conscious about somebody looking at me from the left side and the right side, and my autonomic nervous system is all the time stimulated. When I go to sleep, I don't get that input. So the variability gets reduced. The somatic parasympathetic systems get reduced. That's why during sleep phase it gets reduced. So the baby has what we call as an active movement with lots of fetal movements and accelerations and good variability, then goes to sleep with little input to stimulate the autonomic nervous system, so it has reduced. Then it wakes up again and it has the same accelerations and good variability. So looking at the trace, although we are monitoring the heart rate, what we are really looking at is the integrity of the somatic nervous system and the autonomic nervous system. So I normally say, if you give a baby a ball to toss and play, the baby is tossing the ball, it is like the acceleration. And the baby is smiling, you want to take a photograph, that's like the baseline variability. You don't take a photograph of the variability when the baby has gone to sleep in the pajamas. So you take the best variability available in that particular segment. So by looking at this, you can say this baby is not hypoxic because the somatic and the autonomic nervous system is working well. Now the fourth feature which is not shown is the opposite of acceleration, which are decelerations. The heart rate dropping below the baseline for 15 seconds for more than 15 beats for more than 15 seconds. Now The contractions here are the ones which causes the deceleration. If the contraction compresses the head, one gets early deceleration. If the contraction compresses the cord, they get variable deceleration. And if it reduces the retroplacental pool of blood, they get late deceleration. So looking at this trace, there are no decelerations. That means there is no stress to this baby. So this baby is likely to carry on in labor despite these contractions for hours to come, because it's very unlikely this is going to give rise to any problems. So it's quite important that these features are captured, and when we write about the CTG, we have to say this is the baseline rate, this is the baseline variability, accelerations present or not, and decelerations present or not. Now here again is the challenge for you. Now the challenge here is actually I mentioned about auscultation. Throughout the world, when they do an auscultation, if you look at the notes, they say auscultation, fetal heart rate is 140 beats per minute. Then again they say 140 beats per minute. To me, it is of no value at all. The value is dependent on the intelligent way of ausculting. When I came from the airport, if I see somebody lying down on the road, and if I check the pulse, the person is not moving, I check the pulse is present. So I come and tell, oh, the person is all right because I can feel the pulse, it's about 78. That is wrong, because the person might be down after alcohol or uremia or ketoacidosis, I don't know what. Person is sick, but the pulse rate is present. So if you check the pulse or the fetal heart rate and tell me the fetal heart rate is 140, the baby is okay, what you are telling me is the baby is alive, not healthy. Healthy part doesn't come in when you count a rate. So the normal question we teach our midwives is, when you go to the home for home births, you ask the mother, how are you? She will say, I'm fine. The second question you ask is, how is the baby doing? She will say, the baby is moving. That's fine. And say, what time did the baby move last? He said, well, at 10 o'clock the baby moved last. Write it down and say, mother says the baby moved last at 10 o'clock. The next thing you want to do is to say, I want to listen to the baby and write the baseline rate as 140 or whatever it is. Then you say, I want to feel with you the baby moving, and tell me at that time. So you put your hand, ask the mother to put the hand, and when the mother says the baby is moving, you write and say, mother and I felt the baby moving. At that time you listen. Now the heart rate should have gone up to 160 or 170. That means there is an acceleration present. And then you say the next step, when you feel a contraction, tell me, and you also palpate and confirm the contraction and listen soon after a contraction. There should be no deceleration. So there you have done an admission CTG without a CTG machine by spending a little bit extra time, holding a hand, holding a tummy, and saying the baby moved and there was an acceleration. That is what we call intelligent auscultation. After that observation, where you have observed the heart rate going up with the fetal movement, you can then intermittently auscultate every 15 minutes, because the baby which showed accelerations will not suddenly die. It will show decelerations, a rise in baseline rate, and then only run into trouble unless there is an acute event. So please, fetal heart rate auscultation the way we do has to be modified, where we really interact with the mother, feel for the fetal movements, listen to the heart rate, listen with fetal movements, and listen soon after a contraction. So that is actually a simple piece, and we go on with the baseline variability. Baseline variability is a combination of beat to beat variation. So what you see on the CTG graph is baseline variability and not beat to beat. This one has to be got by a computer, because the CTG machines averages 3 or 4 beats and gives it as a dot. But the bandwidth itself is more than enough to assess the autonomic nervous system integrity. Sympathetic pushing it up, parasympathetic pushing it down. In preterm babies, the sympathetic matures and the parasympathetic is not so mature, so the variability might be slightly reduced. But accelerations are also reduced, and as long as it accelerates by 10 beats, that should be more than enough in the preterm. And more we depend on ultrasound, Dopplers, and Lyco volumes in the preterm. Now the British system has only three categorization of variability: normal, reduced and